If you don't know me, I'm Chief Tom Kulhowick, the Chief here in Norwalk. Welcome to our police department. We're honored to have Senator Murphy, Representative Himes here to talk about, obviously, a very important issue that's been affecting a lot of our communities. So we're going to get started, and I'd like to introduce our mayor to say a few words to start off.
Thank you, Chief, and thank you again for everybody for being here, because we know how important this issue is, and we need to hear from the people out there in the field, people that are affected by this every single day, people who see it every single day. What kinds of resources do you feel will help get us through this epidemic? It's a very, very serious problem. When you look at the numbers of several years ago to the deaths from opioid overdoses to what they are today, the numbers are astounding. So again, thank you all for being here. Thank you to Senator Murphy and for Congressman Himes for caring, because they always want to listen to what is happening in the community. They always want to be there to help. So we're very, very honored and proud that we have two such fine congressmen here with us. So thank you.
Thank you very much, Chief. Thank you to the department for opening up your doors. Thank you to Chief Osborne for being here as well from Darien. Mayor has always been a great friend to both Jim and I. Thank you for Jamie Stevenson for being here, Darien's first select person. Why don't we just do a full round of introductions here, and then Jim and I will make some opening remarks, and we'll give you a little bit of an update as to what has been happening over the last few months, some of it good news in terms of federal funding, and then use the rest of our time for discussion. So why don't we just sort of, for those who have not introduced themselves yet, just go around the room.
Rich Glanville, State Attorney in Stanford.
Ray Osborne, Darien PD Chief.
Matt Grossman, a pediatrician at Yale.
Lee Bodkin, Communications at MCCA.
Jamie Stevenson, Darien's first selectman.
Sally Ann Pelletier, Board Member of Liberation Programs.
Hi, Ingrid Gillespie, Communities for Action of Regional Action Council.
John Hamilton with Mountainside and Chair of the Demas State Board.
Hi, John Duramo, MCCA CEO.
Jaya Deptadar, Chief Operating Officer at MCCA.
Cassie Rossi, American Professional for Communities for Action.
Giovanna Pisani, representing Human Services Council and also Regional Action Council.
So I'm a McCoy student at Western Connecticut State University. I'm studying social work, and I'm an intern at the Human Services Council.
Tanika Benjamin Lewis, Positive Directions.
Patty Riding, AmeriCorps.
Kirsten Nauman, Tribal Partnership Against Underage Drinking and Drugs.
Dina Mussinello, I'm T-Cloud's AmeriCorps member.
Paige Esposito, I'm an intern at Triangle Community Center, and I'm an MSW student at Sacred Heart.
Great, let's go around the back here.
Deputy Chief Ashley Gonzalez.
Lieutenant James Walsh-Moore.
Captain John Lawler, Darien.
Jeff Howard, Communities for Action.
Susan Zephyr, Deputy Chief Common. Nicole Merlo White, Keystone House.
Hi, Devin Fleming, Board Member at Liberation Programs.
Al Mathis, Liberation Programs.
Carrie Ostro, Liberation Programs.
Valacia Brookins, Behavioral Health Social Worker for Value Care Alliance.
Dawn Smith, Recovering Addict, State Car, Bridgeport, Connecticut.
I'm Mike Askew, Manager of the Bridgeport Recovery Center at C-CAR, Recovery Advocate.
I'm Eileen Cardos. I'm the High-Risk Navigator at Norwalk Hospital.
Nicole Hampton, Peer Engagement Specialist, Norwalk Hospital, and volunteer at C-CAR Bridgeport.
Back.
Dennis McCarthy, Fire Chief in Fairfield.
Thanks, Dennis. All right, great. Let's get to it. Listen, you all are in the midst of this epidemic, so you don't need the top line bad news. What we know is that this is an epidemic getting worse, not better, despite all of our good intentions, despite all of our task forces, all of our joint collaborative efforts. We're on pace to have more people die this year from overdose than in a year in our history. And of course, that number is not by any means an accurate way to catalog the scope and the damage of this epidemic. Those are just the people who pay the ultimate price. There are thousands of other lives that are ruined or shattered because of this addiction. And that number is particularly stunning, that we're going to potentially go above 1,000 people dying of overdose, given the massive deployment of Narcan in this state. So even as we have been saving hundreds of lives through the deployment of Narcan to our first responders, we still are going up, not down. We have been working this issue, Jim and I and Senator Blumenthal, for a long time at the federal level. I have never been able to understand why in 2014 the Congress appropriated $4 billion of emergency public health funding to combat the Ebola epidemic after 4 people contracted Ebola. And up until last week, we had appropriated a grand total of $1 billion to confront an epidemic that was killing 1,000 people in a tiny state like Connecticut. To my mind, there was no other way to explain that other than discrimination, other than a belief that is still deep-seated in the minds of many people in Washington that people who are addicted should figure it out. And that it is not a public health concern the way that others are. You all and we all know that to be completely false. The good news is that in the budget agreement that we just passed through Congress a few weeks ago, it includes $6 billion of emergency funding, new funding above and beyond what is already appropriated through HHS, Medicare, and Medicaid for the opioid epidemic. Devil's in the details in terms of how that money is going to be doled out to states. Connecticut generally gets about 1% of any large pot of federal funds. That's what we got based off of the first $1 billion. And so you'd think that that would be somewhere around the number that we will get out of this amount of money. The Appropriations Committee still has to write the way in which this money is going to be sent out to states. I sit on the Appropriations Committee, and so we're going to be doing a lot of that work. But I hope that you'll give us a little bit of a sense today as to what you see is working and what you see is not working when it comes to the way in which we spend dollars, because you're about to get the biggest appropriation of federal dollars for this epidemic since it began, and so it'd be good for us to get some feedback as to how we should write that budget and what we should fund and what we shouldn't fund. And then we just need to convince our colleagues that this is the beginning, not the end, and that yes, we need a lot more money, and that yes, we need them to stop proposing $800 billion in cuts to Medicaid, for instance, that the primary payer for addiction medicine, but that there's a whole host of other conversations that need to be had. I sit on the Health Committee as well as the Appropriations Committee, and I'll just leave it here and turn it over to Jim. When I'm sitting in hearings on the opioid epidemic, I spend a lot of my time talking about how we get all the payers in the healthcare space to start aggressively paying for multimodal pain treatment. Right now, we still have insurers that are easy to reimburse for a pain med, but will run you through the ringer if you want to deal with pain in any other way, whether it be through physical therapy or acupuncture or chiropractic. We've got to have a holistic conversation in this country about how we work people's pain in different ways than a pill. And that is just not happening in the way that it should. So that gets to the source of this more than anything else. So the money is welcome. I'm proud to have supported that. I'm looking forward to the conversation about how it gets sent out. But we've got to convince our colleagues that this is really just the beginning of what needs to be a much bigger conversation about much more aggressive action at the federal level. So let me turn it over to Jim.
Thanks, Chris. And as Chris said, we're here to listen on a very important topic. So I just want to say thanks for two things. One, to law enforcement and service providers and the other leaders in the room. Thank you for your focus on this. We get, as you get, how ugly this problem is and how it is accelerating. I often speculate that I may have one of the most diverse congressional districts in the country. I've got beautiful, affluent small towns like Darien and New Canaan. I've got big cities, vibrant with issues of violence and poverty and everything in between. And the remarkable thing is that on this problem, it is utterly undiscriminating. The most dense fatalities in this congressional district are actually in Shelton, Connecticut, and Easton, Connecticut, a place where people think of going to buy their Christmas trees. And so this is a problem that really knows no neighborhood, knows no social class, knows no rich or poor, and it's getting worse. As Chris said, the good news is the federal government has cottoned on to the magnitude of the problem, and while the resources aren't enough, they are increasing. And so thank you for what you do, and most importantly, thank you for what I think we want to learn here today. The way this process works, Chris alluded to it, the way this process works in the next year, members of Congress in the Senate and the House will be lobbying each other for how to tag, whatever the number is, if it's 10 billion or 13 billion, whatever the number is, how to tag that, how to divide it up, how much goes to law enforcement, how much goes to rehab, how much goes through the medical system. And we can't do that smart unless you tell us what's working and what's not working. So again, thank you both for what you do and for what I hope will be a powerfully educational moment for us.
So let's open this up. We're happy to answer questions about what's happening at the federal level as well, but we really did want to, just as we start to write the rules for this new funding, hear from you about what you think it should be coming down to be made eligible for. So let's open up the conversation to all of you.
So I have my colleagues behind me from CCAR have the most wildly successful program in the emergency rooms now, and they'll be in all 31 hospitals soon. And their engagement rate is like 98%. Has there been any discussion or consideration to move the recovery coach model and some of that assessment into CIT training for crisis intervention with law enforcement, or involved in the criminal justice system, maybe in bail commissioner's office, for pre-prosecutorial diversion?
I mean, I don't think we will never get into that level of specificity at the federal level. I mean, I think the idea is to make sure that we're writing the dollars as they move down to the state in a way that you can use them for the programs that you've found most successful. And listen, we've heard chapter and verse about how recovery coaches brought in at the earliest moment possible and then made consistent, right? Paying recovery coaches enough or having enough recovery coaches so that they'll stick around and that you want to have 6 different recovery coaches during your time. You'll have one is really, really important. And so we want to make sure that the money comes down to Connecticut in a way that's flexible enough for us to invest in these models that you have begun to make work, and then to help advocate with you at the state level to make sure that the dollars flow through them to you. So, yeah.
Yes, Mike Gaston, CCAR. So with the question, I'd just like to ask, would those dollars be approached to state grant budgets, or would that be line items that the Appropriations Committee would provide?
Don't know. I mean, so this budget was written 2 weeks ago, so we're here, soliciting feedback from you as to what are the kind of programs that we should make sure the money is eligible for. The last round of funding came down to the state in a very flexible form that the state was able to then make decisions about how it spent the money without a lot of strings attached to it. This is more money, and so there'd be more pressure to sort of divide it up and have there be a pot of law enforcement dollars, a pot of treatment dollars, a pot of prevention dollars, right? And so that's the conversation that we're in the middle of, but that is not, no decisions have been made.
I'd like to see more monies in the recovery community. Just so that we can provide more recovery support service like recovery coaching and other supports that are provided for people that leave out of treatment in prison settings and need that wraparound service. That would be essential.
Hi, Sally M. Pelletier, board member of Liberation Programs. I observed that the state of Connecticut is quite diverse in terms of Fairfield County and lower income communities. We also have the benefit of wonderful rehabilitation centers such as High Watch and Silver Hill and so on. We do have programs like liberation programs and other support systems for low-income individuals. If I can make any observation and request, is that as the dollars are distributed, that we really pay attention to those individuals at that poverty level. They don't have the opportunity to go to Silver Hill and other programs. They don't have the opportunity for a sober coach, which is kind of a new trend, shall we say. So taking a look at those programs that have been cut year after year after year by the state, naturally we've received many cuts, and to look at how we can appropriate the dollars to those programs for lower income.
Well, I would agree with what you're saying. A year ago, I was hearing in different meetings that you're better off if you have state insurance in terms of getting a bed. I don't know if that's true anymore, because now, well, the beds are mostly full at this point too, though, I believe. So I think that may have shifted. I'm not sure. Maybe others can speak to that in the room.
So, I can actually speak to that. So, as Valley Carolina, just to clarify, is a network that it consists of St. Vincent's, Griffin, Middlesex, and all of Western. So we have created a system to kind of see what our inpatient beds look like, but our detox beds do still, they're very few in number.
So I would like to see some funding go to that, especially considering that a lot of community agencies are not able to take in those individuals who have not yet detoxed. And I think that in prolonging that during the wait for the bed just prolongs the treatment and also makes it less successful because of the lack of
So you
continuance.
see, I know there's a shortage everywhere, we need more of everything, but you're saying you see more of a need for additional detox space than longer-term residential placements?
Yes, because there are community agencies that are willing to engage, but we sometimes miss the window of engagement and that wait for detox.
Right. Okay.
I'd love to see, sorry, my name is Eileen and I work in a program that follows high-risk patients in our emergency room and frequent utilizers, and we put care plans in place for individuals who might come in seeking pain medication in our emergency department. I'd love to see more training for prescribers to be able to do intervention. The ESPERT model has been very successful, but it seems that many times these patients are kind of falling through the cracks. And if there was maybe some screening and intervention at the time of prescribing, we could prevent some of these cases.
And training, tell me a little bit more about what.
So there is one model that's put into place in primary care offices as well as emergency rooms. ESPERT, it's just like it's screening, brief intervention, referral to treatment. It could be administered by physicians or nurses or people who are in the healthcare who have the ability to prescribe, particularly in the pain management setting. And I'm finding that a lot of times we're getting patients who will eventually just, the doctors don't always feel like it's their place to suggest that they go into treatment or to have that conversations. And I think that prescribers and doctors and healthcare professionals outside of the social workers who connect you to treatment really need to be comfortable having those conversations around connecting patients to the right supports.
And that program that you're referring to, do you know who funds that or who runs it?
I do know that there has SAMHSA has a big
program through SAMHSA.
SAMHSA.
Yes.
Yeah.
The Demas has been really encouraging the communities to utilize ESPERT or ASPERT. ASPERT is just an adolescent tool. There are many grants that I know, two off the top of my head currently, that are really focusing on training the communities in that and trying to make sure that once you are trained, how can you actually use it in your work setting? Mm-hmm. That's the difficult part with the tool because there's no policy or procedure. It's just kind of like, here goes the tool, now figure out what to do with it. And of course, not everyone has a lot of time on their hands to really think about that.
Yeah.
I am an ASPERT trainer as well.
You are? Okay. Yeah. Okay. Well, that's good. I'd love to learn more about the program. I don't know it as well. Yeah, I guess one of the interesting things to me as I've gotten deeper into this epidemic is the number, I don't know what the right terminology here is, but the number of functioning addicts, the number of people who are able to sort of hide it for really unbelievably long periods of time, right? I guess that's intuitive, you should know that. I mean, we all know those in our lives, right? But, people who are taking really high levels of illegal narcotics and are able to show up to work, it all falls apart at some point, but it's that interaction with the healthcare system that may be the only time where they're unable to hide it, that the intervention is most important, but maybe physicians, because the person's still showing up to work and hasn't committed a crime, doesn't think that they need to make that immediate referral.
Mm-hmm.
So
then it's the question of who to refer to.
Right.
If you're in a school setting as a social worker or a counselor, they don't have those community resources that those that are in the community already know or have been working with. So there is a lack of communication when it comes to what resources are in our community. But then I also think that it's a lack of responsibility on that individual person. As a social worker, I've always made sure that I knew who was out in the community. So it depends on, of course, the position that you have.
So let me just ask you some question. You run into somebody who's got a problem, who's never been in the system. What's the call? What happens?
So I'm actually somebody else who does direct service will be able to answer those questions. I do indirect service, so I'm really working with community coalitions. I work with the prevention piece of the whole system. So.
But you're training. You're part of the. You're training some of these physicians. So who do you tell them to call?
So I have resources, of course. Regional Mental Health Board, who is here in Norwalk, Margaret Watt. She's come up with resources for our community. So I provide them with those resources. And of course, after any type of training that I do have, it's always ending with resources, but it's also, if you ever need additional, it's always to call me, and I'll help you kind of maneuver through the system if I can.
So Demas has a hotline where you can call and you can find out where beds are and you can find out where treatment is.
You can go right on the website.
Resources on their website as well.
They have a link right to the website.
Yeah, the only thing is beds are not available. I mean, we have the same problem. We have the tax program, the dollars are getting cut every year. Demas asked us to provide mitigation plan, which we provided, but we are afraid now with this plan also will be break even or not this year.
Say again what they.
Because of the funding cuts.
They require you to do what?
Mitigation plan, to plan something out to be, more productive and have break even with the dollars that we're going to get 5% cut this year.
Well, we don't know yet. The challenge, so all the providers are not-for-profit organizations in the state. So our challenge, while we're trying to help everybody during this opioid crisis, our challenge is we never get cost of living adjustments over the past 12 years.
Food cost is increasing.
The cost of just providing care at our detoxes, medication costs go up. So we're constantly trying to just readjust to be able to just make ends meet and pay the bills. At the same time, we're in a state that's in crisis over, the last 20 years that I can think of, budget crises. And you have fixed costs and non-fixed costs. The fixed costs, you can't do anything. They have to meet those costs. Not-for-profits fall into the non-fixed costs. So we're constantly having cuts while we're trying to provide the service that's needed in the community. So, I mean, that's our challenge. We meet it. We always adjust. We meet it. We put in these mitigation plans, and what Jaya was explaining was we took two of our McDonough beds, which are 30-day rehab beds, and moved them to the detox side. It helps us because it takes out of a grant side, puts in the fee-for-service side, and they're both needed. So there's a need out there for both beds, but at the same time, you lost two 30-day rehab beds in the process of mitigating the cuts from the state.
And now the problem is, now we have 14 detox beds, but now we don't know where to send them after that, because we got 2 beds cut from the 30 days. 2 less
beds we would have referred from detox into the McDonough
30 days
side.
essential.
So these are just the day-to-day challenges that a not-for-profit faces in today's situations in the state.
And also Medicaid rate. I mean, the rate is not increasing. Repayment is the same, but the cost of living has been increased.
What is there more demand for you guys right now, inpatient or detox?
Both. It's pretty much both. Because detox feeds to the rehab, so you have to detox before you go into the rehab.
We have waiting lists that we don't know.
I'm Eric Collins. I'm an addiction psychiatrist. I'm the physician-in-chief at Silver Hill. This is a complex problem which has been going on for a long time. You don't have to detox before you go to a rehab unless the rehab doesn't let you come in. So let's, for a minute, detox means getting off the opioids, but 2 of the FDA-approved, well-established treatments that work for addiction to opioids are methadone maintenance and buprenorphine maintenance. Many rehabs won't take you if you have those. That is a backward view, and it's part of the whole, Senator and Congressman, maybe you're well aware of this issue, but it's a problem in our field that many rehabs, many residential type treatments won't take someone without a detox. I don't know that more beds will be the answer, because addiction is always a chronic, typically remitting and relapsing illness. That we can give people residential treatment, but if we don't give them something for the long term, if I would analogize it to someone with diabetes coming in, getting their acute blood sugar abnormalities adjusted on the inpatient basis, maybe getting some coaching or training for a few weeks or a month, and then if they don't really keep up their energy and effort to take care of their diabetes will go out of control again, and that is typical, many of them, for many. And that's really the story we have with addictions, whether it's opioids or others. Opioids are the most pressing because there's so many opioids out there, and now so many deadly opioids out there. But you don't have to detox. And what we really need, I think, is better funding for the treatments that work. And I only named 2 of them. There's another one that's not so controversial, which is not an opioid-based one. It's an opioid antagonist or blocker, and that's an injection. It's rather expensive, and so paying for it is a problem. Pardon me? Yes, Vivitrol is what I'm referring to. One of the problems we face often, we doctors who want to treat people, those who have resources, is that insurance companies make us get on the phone for 20 minutes and get an approval, or they won't pay for it. And that eats into time. We either do it ourselves or pay staff to do it. Complex problem, lots of issues. We all want to do what we can to help. I just wanted to sort of give a sense of that, because you don't have to detox to go to rehab unless the rehab requires it. And
or you're not on medication-assisted treatment. That's what I was referencing. And then you have to detox. You can't come into if you're not looking for Suboxone, buprenorphine, or methadone, and you want to get off the opioid, you can't just go directly into a rehab. You would have to detox first. That's what I was referencing. We do allow people to come into our programs on Suboxone or methadone, into our long-term and our 30-day rehab.
And I would agree with Dr. Collins. Absolutely, we should focus more on meds over beds. There's a place for beds, but we can treat so many more people if we had a no wrong door approach and gave them the access to all 3 FDA-approved medications. Now, buprenorphine actually has an injectable form, which can help a lot of issues around diversion, particularly in the criminal justice system. But we also have to emphasize that it's medication assisting treatment and recovery, not replacing it. So it needs to come with recovery coaching for the family, recovery coaching and counseling and psychosocial supports. And that's part of the problem too. There are some physicians out there, not Dr. Collins and Silver Hill, because they do a great job, but are just giving out the medication, and all it has now is street value and diversion for buprenorphine, because they're not getting engaged in the recovery process. So is there a way on a federal level that you can standardize the new standard of care for opiate addiction, to have them recognize that they should have some level of informed consent of the medications out there that will save their lives? Because without it, in the first year, there's over a 90% chance of relapse.
Yeah, I think the short answer is probably no. That this is not something that's going to be solved by politicians in Washington, but it is the most frustrating part of this public policy problem for policymakers, that you have very strong feelings within the community about particular pathways of recovery, and you have some people who say great things about Vivitrol. You have others that are going to talk it down. You have some people who swear off all medication therapies, right? Everybody approaches this from a different perspective, which confuses the hell out of policymakers, and confuses the hell out of people in recovery seeking help as well, because they get lots of different advice as to which way they go. So I don't think that the solution is coming from Congress. I think the solution has got to come from within the recovery and treatment community to try to get some, maybe there will never be firm answers, but this is pretty confusing for everybody that's involved in it.
I apologize, Senator, I'm sorry. The answers are fairly firm. All 3 approved medications have robust research supporting their use. The problem is it's better than it was. It's moving in the right direction over the last 15 years, but it's not what it what the research suggests it should be. I'm not saying every person should get on any of those medicines, but we do know all those medicines help facilitate reduced relapse rates, reduced overdose deaths, and long-term recovery. And it's confusing for policymakers because there's some very well-meaning people with great conviction who want to help the world, and they believe very firmly, despite medical evidence, that some of those things shouldn't be used. And that's why it's partly confusing. They have a strong opinion in it. I know they're coming from a good place. They're just not looking at medical research. It's one of the, if you think about it, it's one of the only areas in all of medicine where public opinion so influences the way things are done. Maybe public opinion, but rather than medical research.
I have a question, more on the prevention end of this, but for the recovery people, I read about something called a Medicare 16-bed waiver. Can anyone explain to me how that would work, and has Connecticut applied for it? Several states have, and it's opened up a lot of treatment beds.
I don't know if anybody knows what that is. I don't know what that is.
I've emailed the commissioner about it.
Yeah, so several states have used it. It's an obscure Medicaid law that facilities larger than 16 beds cannot use federal money or something.
All right, so there's a general exclusion. Yeah, so there's right. So there's a general exclusion on Medicaid dollars being used for long-term treatment in the mental health and addiction space, and this is rooted in a world 50 years old in which you were trying to prevent Medicaid dollars from being used for institutionalization. And so I have been, so if that's what you're talking about, so we have been working for a very long time on trying to remove that exclusion, at least increase the number of beds that you can have or the amount of days that you can be in long-term beds and still use Medicaid dollars, but that is a enormously expensive endeavor, but again reflects good medicine and good science. There are some people who need those longer term placements.
It sounds like it's something that these states have applied for and they've just gotten the response.
I don't know that that's true. I don't know that this is something that you can easily waive your. If we're talking about the same thing, you cannot. This is called the IMD exclusion. You cannot easily waive out of the IMD exclusion unless you're willing to pay state dollars. But we can make sure we're talking about the same thing.
Okay, great, thank you.
Yeah.
One of the common themes around that where we found success with opioid prevention, abuse prevention, et cetera, is just the concept of engagement. How do you engage? And so in terms of funding, we have a system called the Connecticut Prevention Network. Giovanna and I are both members of that, and we are all ASPERT trained. We've got some of these trainings that we can do. But I think the point around prevention in terms of being able to engage at the local level is having, if you have a system where we reach out to 169 towns and we're there, but like everybody else, we're stretched to the dollars. So when you're looking at dollars, look at present systems where they do readily engage people in, certainly from the prevention perspective. The other piece is scope of pain is an evidence-based training that is offered now in Connecticut to prescribers. We work with hospitals to get prescribers educated on this. Sometimes there's a challenge. Now, in our field, in alcohol and tobacco retailers, and the police will know this, is that when we do the alcohol training, one of the incentives we say is, if you get this training, insurance companies will give you lower rates. The Joint Commission came into the hospitals and said, you need to do this, you need to manage this pain. It's directly tied to your funding. Do you have any ability to work with the Joint Commission to offer some other kind of incentive to hospitals that say, look, you get every prescriber related to your hospital trained in something like scope of pain, and there's some kind of
What is scope? I guess I'm sort of missing a little. What is scope of pain?
It's an evidence-based opioid training for prescribers, and we have it in Connecticut. We've got
That's intended to do what? To
educate them about understanding opioid addiction, safe prescribing.
With the end goal being the end goal being less prescribing.
Yeah, and it's a good, I think.
Pain management with less opioid.
Thanks. Yeah. So Dr. Collins, you can speak to it. I mean, we've done one in New London. We've got one coming in New Milford. But There's been a challenge in terms of just getting prescribers to the table, looking at Matt and I work together. But we realized that it was amazing how people prescribed when the Joint Commission did a reverse and said, hey, you know, you guys have to manage your pain better, the hospitals, and it's tied to funding. Couldn't we do something with the Joint Commission where we, you know, working with them? I'm not saying that that's a dollar attached to it, but at the federal level, can you know, sort of a standard around that? Because it's like, if we could do it to get them to prescribe more, and I realize, you know, the pharmaceuticals came in at the right time, but couldn't we do something with Joint Commission, say, hey, can you look at some kind of incentive program for hospitals that says, we'll give you this if you can get every prescriber trained in an evidence-based training. That would be, from a prevention perspective, that's significant.
Yeah, no, I'd be happy to,
Yeah?
be happy to take a
And the
look
other
at that.
thing we're working on is we have a statewide group that's working on getting opiates in blister packaging, unit packaging, and FDA, when did the FDA meet?
We had a meeting December 11 and 12 with the FDA
in Maryland.
conference.
They did a 2-day conference, and they're looking at mandating unit packaging for opioids. And we introduced legislation last year. It didn't pass, but it'll probably be introduced. But we are really the only country in the world that doesn't do this. And when you hold up 2 pill bottles to anybody with Tic Tacs in them, and you say which one is missing 2 pills, they don't know. They would know in this.
Right.
The version would be, and medication adherence, which costs us a lot, 200 and some billion.
$230 billion a year.
Yeah. So from that perspective too. So we will be reintroducing it, but the FDA is really seriously looking at that. So any support around exploring that would be great.
Great, yeah, those are 2 good suggestions. So some of this money will come through DOJ, so maybe Chief, I don't know if you or somebody else wants to talk a little bit about, you know, just sort of trend lines that you're seeing in the distribution networks and the ways in which federal funding for enforcement would make the most sense.
Well, as far as what we're saying, I'd actually like to turn to Lieutenant Walsh, if you don't mind, just to give us, he's in charge of our narcotics unit, and he can just give us an overview of what the trends you're seeing right now. And
Mostly the trends is heroin mixed with fentanyl, mostly coming from lower areas of New York City, Dominican supplies, South Bronx. A lot of the traffickers are carrying it down I-95 or via train in bundles or bricks, which is large wholesale quantities, and they're distributing it on the street, mostly via cell phone. We don't see the open-ear drug corners that we used to in the early 90s, late 80s. Most of our trafficking is done by cell phone off of known drug suppliers.
And so what are you seeing in terms of, you know, this year versus last year before, in terms of the fentanyl component? How much fentanyl, pure fentanyl, what do you, I mean?
We're still, most of our investigations are still gleaning a lot of fentanyl, but we haven't had a fatal overdose since October. Most of our,
you can jinx us.
Sorry. Most of our overdoses have sort of slowed down. We've had 89 since September 2015, 23 fatal. Last year at this time, we were getting a lot more. It seems like some of the street users have acclimated to fentanyl usage, and their bodies have adjusted. So some of our investigations were actually purchasing bags mixed with fentanyl, and we're not seeing the overdoses as we did a year ago. And that's the only theory, that somehow people are adjusting to fentanyl usage.
Where is it? I'm sorry. What do you know about where it comes from?
Yeah.
Most of the sources are Mexico. They're actually, the cartels are mixing it for profit. They're lowering, they can make a kilo of heroin much cheaper by adding fentanyl purchased from China. So they're stretching the product and making more profits. So most of it's coming in communication with our task force officer, and DA, it's already prepackaged in kilo size, already mixed with fentanyl. And we've had a few cases locally of wholesale drug dealers on the black market using the dark web to purchase fentanyl from China and mixing it locally, which is a new and current trend, but most of it is coming from Mexico.
Yeah, Nicole Hampton, Norwalk Hospital. I was saying about the dark net. Like your kid can go online and order fentanyl or carfentanil, and it comes to your house in like an Amazon Prime box. Wow. They can order like any drug off of that website. And it's all majority of the drugs are coming from China though. It's called a dark net.
Not through Amazon, not on Amazon.
No, like that's how it comes packaged.
Oh, it comes packaged.
As an Amazon Prime, so you think your kid ordered, you know.
That whole dark web, like, do you know, like, what exactly is that?
Well, you can basically go on there and like order any drug you want.
But that's like not the regular web, when you say the dark web.
No.
Like Silk Road, I was talking about.
And I think it's like darknet.com or something like that. I had the link in my office.
There's like 3 or 4 major conduits to the dark web, and most of their commerce is done in Bitcoins.
Wow.
So of the
Yeah, it's bad.
1,050 deaths last year in Connecticut, 675 of them included fentanyl, according to the chief medical examiner.
Do you have information on how many of those, of the 1,050 included benzodiazepine medications as well?
I think it was 200.
Roughly 1/4 of all of our overdose deaths are a number, a combination.
Multi-drug.
Multi-drug. They're not singular, and they often have other sedatives like benzodiazepines.
Right.
Hi, I'm Dawn. I'm a recovering addict. And I'm gonna tell you from experience, a lot of drugs are transported through UPS ground, and there's a way that you could package it, and this is from personal experience, so I'm speaking from my heart. There's a way that you could package it, and it comes from Mexico, it comes directly through customs, and it passes through the dogs, they cannot detect it. And it came directly to my house, UPS ground. So I'm letting you know that this is from experience. Okay? So I am in recovery. I'm, speaking truthfully. And I wanted to let, law enforcement know that yes, this can be done.
And you were saying that it's a relatively new phenomenon to have fentanyl shipped here and mixed locally, but that's something you're seeing.
We first saw it last summer, early fall, in one of our investigations, but it is becoming a growing trend, being passed along to save money by wholesalers.
But this has been going on,
Oh, we're aware.
to my knowledge, since before 2015.
We work closely with U.S. Postal, UPS, and we do box interdictions with the dog at their major parcel centers, where we have all the dogs sent through boxes, and we have been successful, but we do realize that some skips through.
Do you have someone, it's Devin Fleming with Liberation Program, I'm assuming you have someone putting together the statistics. I was just thinking as Jamie was speaking that it would be nice, and I know it's a fluid situation, you have lots of moving parts, and it must be incredibly confusing, I think, to everyone, because what works for someone doesn't work for someone else. But I think it would be important, because what you're seeing here in this town would be very different than what you're seeing in, say, Shelton or Easton. And so I would think to have the actual numbers broken down for the state as to deaths, what programs are available, how many people those programs are serving, and so you can get an idea of the situation, the problem, and the solution. And you're going to get lots of different opinions as to which programs are better. Some of them are just, in the region. We have a new building that we're putting up in Bridgeport, completely unique Bridgeport Health and Wellness Medication Assistance Program. Also in Norwalk, one of the only programs in the state that offers women and small children, or women who are pregnant, recovery services. So you're just not going to know necessarily about all these places. But maybe if, someone that could help you look at the facts, the statistics, and how that's changing with time. Fentanyl's a problem. There's nothing you can do about the dark web. You can't attack that, right? The programs and services that are available and what towns are available in relative to the problem. How many programs and services are available in Easton and Shelton? I don't know. Where are they going? Bridgeport? They should. So I think someone just to look at the actual statistics and what's happening and who and what services and programs can help, and then that, and it's different. You've got dual diagnosis here too. This is not just a substance abuse problem. You've got the mental health issue. I mean, it's crazy. And one person has a dual diagnosis, another person is just alcohol. Coming off of alcohol is much more dangerous than coming off of heroin, and you wouldn't necessarily know that. So these are things that that need to be understood before you can start divvying out the money.
The $6 billion, which is, to clarify, is $3 billion this year, $3 billion next year, can be used for both substance abuse, the opioid epidemic, and mental illness, and so. That's the other challenge here, is getting that distribution right about how much of that money, and SAMHSA will control a lot of that, but how much of that money is earmarked for mental illness versus substance abuse. I think my hope is that it's as flexible as possible to states, so that they can use it for whatever they think is the programs that work best. So yeah. Sure, go ahead.
Jamie, you want to go first?
Sure, just one other issue, and Ingrid can talk to this too. We have great difficulty in getting real-time data on the magnitude of the issue because of the way overdoses are reported or not reported. We always end up knowing that ultimately the deaths from overdose, we have to wait, a little over a year to get that information, but we don't get real-time data on overdoses that don't result in deaths, because in our state they're reported as poisonings. And so I know that Ingrid and many others are trying to work on a system of data collection that honors our HIPAA laws, but also can give healthcare professionals and law enforcement real-time data on the magnitude of the problem.
Right. Is that something we can solve?
Yeah, I think the whole system, two things, sort of real-time data and data coordination. State level reps will tell you that's a struggle. And certainly the dollars invested in that. But we're looking at right now, our health departments, they get data, somebody gets the flu, somebody, whatever, they get that. But they don't get the data, the real-time data on these other alerts, and they are HIPAA exempt, so we're not talking about violating anybody in terms of that. But when they get that real-time data, and HIDA, High Intensity Traffic Association, has shown that when public health can certainly work with law enforcement, times where it's appropriate, we're able to get those dangerous drugs off the street, but also we're able to do better alerts and those types of things, and the interventions that we're talking about. Right now they get it like a year later. That's going to show you trends. All of us can get trend data. What we're trying to do is get a handle on it ahead of time. So health departments would be a natural repository for that type of data.
All right, we're going to go last word here because we got to wrap up. So.
Okay, I just had a question about that, but another point really quickly. Why is it HIPAA or 42 CFR that governs this drug? Why is there an issue with the data? It makes all the sense in the world. We should get that data.
It's neither. That's not a federal issue that Ingrid's been working on. That's a state issue, I believe.
Okay.
That's an issue that people in Hartford could change.
They're not looking for the the individually identified data.
No,
absolutely right. So as long as you're not disclosing it.
Right. Okay. So thank you, Senator. My last question, and it's much more controversial for a variety of obvious reasons. And I'm not here to advocate for it. I just want to ask about some of the more controversial approaches like supervised injection facilities, which in other countries have, and they're starting up in a number of cities in this country, but in other countries they have demonstrated a way to engage people who have the illness, who aren't yet ready to make a change. Because at the end of the day, that's really one of the issues. If we could, I mean, if you want to ask the owners of fast food restaurants, overdoses in their bathrooms is a problem throughout the country, public bathrooms. And so, besides naloxone, which maybe you covered before I got here, I'm not here to advocate for SIF, supervised injection facilities or other things like that, only to advocate that you be open to looking at evidence for whether they actually help, and maybe steering some of the funding into pilot programs to see if they're useful, at least in this country, because they do seem to be in other countries a little.
I know you just said this is the last word, but I apologize for being in and out of the room, but did anyone talk about the lack of nurses who can get people up and going with Suboxone? Because it's a complicated process, and we struggle with that cost and and Demas wants us to, that's really, correct me if I'm wrong.
Well, APRNs are now allowed to prescribe, so the federal law now allows you want to answer that question?
Yeah, I was just
so
gonna
I
say
apologize.
that,
We have to.
We actually look at that in our hospital, and we're trying to set that up in Danbury across the network. But one of the biggest problems we find is not that there's a training process that physicians or nurses have to go through to prescribe, but then once they are outside of the hospital or whatever facility there aren't as many places that people can go to be monitored on in the community.
No, not at all.
So it's that referral link that we're missing. And just a quick comment on the data, one of the biggest issues I'm seeing in data collection, because I actually monitor all of the ODs that come into Norwalk Hospital, not just fetal, in real time. I get the data from anyone who has responded to Narcan in the field, and then I have a series of data points that I collect in real time, and we monitor our issue as well as any plan we put into place in the emergency room that has come up for frequent utilizers who are coming and seeking opiates or benzos. But I apologize for losing my train of thought. But that there's one of the biggest issues is there just aren't people collecting that information, and then when it comes to the Suboxone, we can't refer them to the community.
Well, and it's a challenge. It is a challenge to find, it's a cost, and then finding people that can do it. And I think for other nonprofit providers, it is as well.
With the lack of funding, it's hard to bear that administrative cost of entering the system as well.
Thank you, everybody. I know there's a lot more comments, but I will be horribly late for my next 7 stops if we don't. So this, listen. Jim and I go through this a lot. We just want to continually touch base with you and make sure that you're in contact with us and our staffs as this process of the appropriations level continues to play out. So thank you, everybody. Thank you.